Hi, everyone. I'm Chris Rogers, and I work with the Vision Aware program. And we're really happy to be doing our second part of our webinar on medications and diabetes with Kim Ladd, who has done several webinars for us on diabetes. Kim is a registered nurse, and she's also a certified diabetes care and education specialist. Kim, we're really lucky to have her because she is updating all of our diabetes materials on Vision Aware, and we hope to have a lot of them ready for Diabetes Month, which is in November. So today we're doing the second part of the webinar on medications, and today's has to do with injectables and insulins. On November 17th, we'll be doing a Q&A session which will go over both of the webinars, the first one that has been recorded and this one. And then you'll be able to ask questions once you have listened to the two archived webinars. And we'll have the information up online so you'll know how to access those two webinars. So we're really happy to have you today, Kim, to talk about the diabetes injectables and insulins. Thank you very much. Take it away.
All right, thank you, Chris. Let me share my screen here so we can have the PowerPoint that keeps me on track. Once again, this is part 2 about diabetes medications. Understanding the different types of diabetes medications can help improve your health. This is part 2. I'm going to talk about insulins and injectables. You know, I really could talk, hours and hours about medications, especially insulin. So I'm not going to give you all of the ins and outs. My goal here is kind of to give you an overview of the types of insulins and injectables, just to give you some more information. And, and then you can take the time to research the specific ones that you're on. There is a handout that goes with this webinar, and I believe you get it when you sign in, or we can get it to you. And as Chris said, we'll have a Q&A section in November during American Diabetes Month. So we'll go ahead and start. So this webinar will help you gain an understanding of the different types and actions of diabetes injectable medications and how they help regulate blood sugar levels. The objectives are to increase your knowledge base of the different types of insulins and how they help lower blood glucose levels, to help you gain an understanding of the non-insulin injectable medications that can be used to manage type 2 diabetes, and to apply knowledge gained to be a part of choosing which diabetes medications will work best for you. You know, it's very important for you to be knowledgeable of medications that you take for any chronic disease, especially diabetes, since it's such a whole body disease. The more information you have, the more power you have over managing that chronic disease. I know it's kind of corny, you hear that saying, knowledge is power, but it's especially true for something like diabetes. You want to have as much knowledge as you possibly can. All right, so why diabetes medications? Again, the cornerstone of diabetes management is keeping your blood sugar levels under control. So if you're checking your blood sugar, you want that level to be between 80 and 130, or less than 180 within 2 hours after eating. Now, these are the American Diabetes General Guidelines. If your doctor wants you to be in a different range, go with what your doctor says. But overall, 80 to 130 is where you want your blood sugar level to be to help prevent complications of diabetes. Another cornerstone of that is the hemoglobin A1C level, which is the blood test that the doctor, that is drawn at the doctor's office. It shows your average blood glucose level over the previous 3 months. You really want that number to be 7% or below, because studies show that when it's 7% or below, that helps prevent the numerous complications of diabetes. So, one way to help keep your blood sugar levels in check is by taking your diabetes medications. So that's why it's so important to know about them. All right. So insulin. This is a video that I like to show. It is on YouTube, and excuse me, but it does have like a commercial break in the middle. So I had no way to kind of get around that because I don't have a YouTube account, but I wanted to show this because it is from a physician assistant who specializes in endocrinology. He has this website called Sugar High, and I like the way he explains things. Insulin it's a little difficult to understand sometimes, but insulin is a hormone in our body that's made by the pancreas, and its main function, among other things, is to regulate glucose metabolism, which means as you eat foods and the foods are turned into sugar, insulin's role is to get that sugar out of your bloodstream and into your cells for energy. So when you have diabetes, you don't make enough insulin from your pancreas to move that sugar out of your bloodstream into the cells, or either your cells aren't receptive to the sugar and insulin. So that is why some people that have diabetes need to be on insulin shots. It's a, it's a synthetic, man-made product to mimic the natural insulin that our body makes. So this physician assistant has a great way of explaining it. So I'm going to turn this video on. And like I said, bear with me with the commercial in the middle. It is about an 8-minute video, but it's worth a listen. So here we go. Let me get this up. Give me 1 second. Technology is always fun when it works. I got to share sound so you can hear it. All right, here we go.
If you want to understand diabetes, step is to understand what insulin is and how it works to control the blood sugar level in our bodies. So who's ready for a molecular biology lesson? Anybody? Nobody? Welcome to Sugar High, guys. I'm PA David, your glycosylated guide, and today we are making insulin easy to understand. By the end of this video, you're going to be an insulin pro, and you won't even have to take notes. All right, first things first, you need sugar. Glucose is your body's favorite source of energy. Your body runs on glucose like your car runs on gas. Yeah, I know. If you have an electric car, you don't need gas, but you get me, right? Glucose absorbs from your food into your bloodstream so that it can travel to every part of your body. Your blood vessels are like a highway, and all the chemicals that we need get delivered as the blood flows and circulates. Your body cells want that glucose inside so they can break it apart and get the energy out of it. Think of it like Amazon trucks driving on the road to deliver packages to your house. Glucose is the package, and your house is the cell. But the Amazon delivery person doesn't break into your house and bring the package inside. They just leave it on the doorstep. It has to still get in somehow. And glucose is the same way. It can only get into the house or the cell through the front door. And that door is locked. Lucky for us, we have the key. And insulin is that key. Okay, I know the whole insulin is the key that unlocks the door analogy gets used all the time, and it's tired and it's overused, but it works. That's one of the easiest ways to understand the most basic role of insulin, and one of the simplest ways of describing how diabetes works. Diabetes is what happens when something in that whole lock and key system breaks and the door doesn't open. Okay, insulin is a hormone that gets produced by your pancreas, which is this pretty weird looking organ right in the middle of your abdomen below your ribs. In addition to insulin, your pancreas also makes a hormone called glucagon, which has the opposite job, raises the sugar levels, as well as some other enzymes that help us to digest our food. There's this specific type of cell in your pancreas called a beta cell that's in charge of making insulin. Once insulin gets released from your pancreas, it only lasts like 5 to 10 minutes in your blood, which is good because that allows your pancreas to adjust the amount of insulin on pretty short notice and manage when blood glucose levels change throughout the day. Your pancreas makes a steady amount of insulin all day long so that it can keep your sugar level at a normal baseline. Now, since this is a baseline trickle of insulin, we call that the basal rate. But when you eat something, your food absorbs and this extra rush of glucose starts flooding in, so your pancreas has to squirt out an extra bit of insulin to cover for this bit of sugar and bring it back down to baseline. Once the meal has been managed, the pancreas backs off and goes back to releasing its normal basal rate. If you've ever seen someone give injections of insulin, you might have noticed that insulin doses try to follow this same pattern. Some insulins are injected just once a day and last all day as that basal insulin. Some insulins are faster and shorter and get injected just before eating in order to cover for the meal, just like your pancreas otherwise would. But remember how we described insulin like a key that opens a lock? Well, it turns out that insulin actually has more responsibilities than just that. There's a bunch of different parts of your body that help control your sugar. And insulin's effect on each one of those is to modify it in whatever way would lower your glucose. Like, for example, remember when we were talking about the other hormones that the pancreas makes, and I mentioned that there's this guy called glucagon, and he raises your sugar? Well, guess what insulin does? Insulin blocks glucagon from getting released so that it can't raise your glucose level. There's also several ways that your body stores sugar for later, kind of like a bank account. And there's even different kind of bank accounts in your body. Like you may have a savings account, but you may also have a retirement account, and those store money in different ways. If you think of glucose in your blood like money in your hand, insulin basically wants to get the money out of your hand and do something with it. Anything. Just get it out of my hand. Either spend it or save it. Spend it by letting it into the muscles and burning it up, or save it by funneling it into one of our savings accounts. The quick and easy savings account is in the bank of your liver. Your liver stores sugar inside it in the form of this thing called glycogen, which is really just long chains of glucose strung together like pearls on a string. In reality, it branches off in tons of different directions, but just think of it like pearls on a string, where each pearl is a molecule of glucose. If you need that glucose, you can tap into that bank account and start unlinking pearls from the string, and that leaves you with a bunch of glucose that's ready to be used. You can also store the energy from glucose in your retirement account, which is called fat. Glucose is used in the formation of fat molecules. We don't spend that money as quickly as we spend the glycogen in our liver, but if we need to, it's there, and breaking down fat produces molecules of sugar. And if we've absolutely tapped out all our savings and we still need $1, we can hawk our belongings by selling off our proteins. Yep, even proteins can be broken down and converted into glucose if you really.
This is
Lumen, the first device for hacking your metabolism. With just one breath, Lumen tells you what you're currently burning for energy, carbs, or body fat.
Really need it. The effect of insulin is to block all of these glucose storing bank accounts from getting tapped into, and it even promotes depositing that sugar into each one. It blocks glycogen breakdown. It blocks fat breakdown. It blocks protein breakdown. So I'm hoping that by now insulin is starting to seem really helpful and like a good thing. And the reason that I bring that up is because I want you to look at insulin as your friend. Insulin is a good thing. It belongs in our body, so we shouldn't be afraid of it. Sometimes we need to use insulin to control diabetes, and insulin has kind of gotten a bad rap. In my practice, I've seen that a lot of people are really afraid of starting insulin, even beyond just the idea of giving themselves an injection. Insulin sort of has this stigma as being this symbol of the beginning of the end to a lot of people. And a bunch of people have told me that they really don't want to go on insulin because they're worried that it might cause dialysis or blindness or cause them to die earlier. And these feelings are usually based on some sort of personal experience where they saw a family member get put on insulin, and then in the years that followed, things didn't really go that well. Sometimes the natural inclination is to conflate the two, to connect the two, and assume that there's this cause and effect relationship, like as though the insulin caused the kidney failure and made the person go on dialysis. Guys, it doesn't work that way. Insulin doesn't cause kidney failure. Insulin doesn't cause blindness. Diabetes causes those things. And if we can keep a good handle on blood glucose levels, we can often prevent those things from happening in the first place. And I'll admit that as healthcare providers, we're sometimes guilty of waiting way too long to start insulin in people who needed it. Quite often, if we would have not been so afraid to have the conversation with a patient that it might be the right time to start insulin, we might have been able to get better control earlier on and things might have gone differently. Now, I'm not saying that if your family member went on dialysis, that their doctor was bad or guilty of malpractice. I just really want to dispel some of the myths that I see so commonly that keep people from jumping on opportunities that might have freed them from the very things that they were afraid of. So that's how insulin works. What do you think? Does it make more sense now?
All right, let me stop sharing that. So I hope you gained some insight from that video. Like I said, I like the way he breaks things down and explains everything. Let me get back to my slideshow here. Okay. All right, so basically, like he said, you know, insulin, if your body cannot produce enough insulin, that's what diabetes is. You know, I spoke a little bit in part 1, but just as a refresher, you know, there's different types of diabetes. There's LADA, which is latent autoimmune diabetes in adults, which is kind of like, they call it diabetes type 1.5, or it basically kind of starts out looking like it's type 2 diabetes, but then it turns into type 1 diabetes. And there's a few other ones, but you know, the main types of diabetes are type 1 and type 2. So that's basically what everyone kind of refers to. Type 1 is a autoimmune disease. For some unknown reason, your body attacks your pancreas and attacks the beta cells and makes it so your pancreas can no longer produce insulin. So if you have type 1 diabetes, you have to be on insulin shots to live. Type 2 diabetes, I like to call it that your pancreas is tired. So over time, your pancreas kind of gets worn out and it's unable to produce enough insulin that your body needs. Now, there are risk factors for that. Usually there's a genetic component, like people in your family have it. I've said on these videos that I have diabetes. That's one of the reasons that I teach about it. I'm so passionate about it. You know, like everyone in my family had diabetes. So I pretty much was prone to get it if I didn't take care of myself. So of course, in the time in my life that I was really overweight and stressed out and not eating healthy, that's when I was diagnosed with diabetes. So that's type 2. Your pancreas still produces some insulin. So sometimes when you get diagnosed with type 2, you can first control it with how you eat, you know, with low carbs and, you know, watching your just your nutrition level overall, and exercise, which helps lower blood sugar levels. But eventually you tend to get to the point, through no fault of your own, it doesn't mean you're a bad diabetic or anything, you get to the point where your pancreas still just cannot keep up, so you need the help of some medicines. So in part 1, I talked about the by mouth PO medicines, and those are really for type 2 diabetes. There are some instances where doctors will put people with type 1 diabetes on some of the by mouth medications, but they're rare. So mostly insulin. This is more directed to type 1 diabetics, since you have to have it, but some people with type 2 diabetes also go on insulin. Usually the longer you have type 2 diabetes, you know, the more you'll need to go on insulin, because your pancreas finally just stops working. So anyway, so like I said, if you have type 1 diabetes, you will be taking insulin. So insulin doses are drawn up from either of a glass vial using a syringe, a pen that literally just looks like a pen. You attach the needle to the end, and there's a button that you push to inject the insulin, by an insulin pump, which is a device that kind of looks like a pager. If you remember pagers from the 80s and 90s, it's about that size, and it has a tube that goes to it, and you insert a needle into your fatty tissue, and it delivers insulin that way. Or there's like the Omnipod system, which is a type of pump that is a one-piece kind of capsule that has insulin in it that you usually insert on your arm, and it is programmed to deliver insulin over a certain amount of time. So, and then there's also an inhaled insulin. So right now, those are the types of insulin administration modules that are available. You inject insulin into your subcutaneous tissue, which is also called sub-Q tissue or fatty tissue, which usually you inject it into your abdomen, at least 2 inches away from your belly button, you know, your legs, the back of your arms, or your buttocks. Insulin cannot be taken in pill form because your digestive system would break it down in the same way that you digest food. So that means the insulin wouldn't make it to your bloodstream where it's needed. That's why you have to inject insulin. You cannot take a pill for it. All right, so this is just a little bit of history. I'm a history nut. It's actually the 100th anniversary of insulin. Insulin was developed in 1921. A Canadian doctor, Dr. Frederick Banting, and his lab assistant, Charles Best, they produced an extract that they could inject into diabetic dogs. They then began to produce extracts from the pancreas in cows, and they called it extracted insulin. So once they kind of perfected the technique, in 1922, the first insulin dose was given. It was to a 14-year-old who had type 1 diabetes. He survived 13 years, which back then was a miracle, because before the invention of insulin, there was no treatment for diabetes except basically a starvation diet, because they knew when a person ate, it raised the blood sugar level, and that's what caused the problems. But they didn't have any type of medicine to help move the sugar out of the bloodstream into the cells like insulin does. So the pictures, I've seen pictures of like before they invented insulin and after, and all the pictures before, all of the children are just skin and bones. And then they'll give them insulin, and then they'll show a follow-up picture like 6 months to a year later, and they're nice and plump and the weight that they're supposed to be. It's just amazing. So that was 1922. In 1950, Novo Nordisk, developed NPH insulin, which is an insulin with an intermediate action effect, and it improved the ability to control blood sugar. In 1963, insulin became the first protein that humans learned to manufacture artificially. So before 63, they were actually taking pancreas from animals, cows, grinding it up and making insulin. In 1963, they were able to make synthetic insulin, so they didn't have to take the poor cow's pancreases anymore. In 1982, insulin made artificially begins to be called human insulin. And it turned out that human insulin is better than insulin extracted from the pancreas of animals. In particular, the risk of infections and allergic reactions is lower when using human insulin. And Eli Lilly was the first company to launch human insulin, which is still in existence today. 1985, Novo Nordisk launched the insulin pen. So the insulin pens have been around for years. They just haven't really become popular except in the last 10 or 15 years. In 1992, a company named Medtronic launched the first insulin pump, and they still make insulin pumps. In 96, Eli Lilly launched analog insulin Lispro under the trade name Humalog. Analog insulin is a modification of human insulin, and this modification gives insulin other properties, such as the rate at which insulin is absorbed, distributed, and translated into the body. This has allowed insulins to last longer. The PA in the video is talking about basal and bolus insulins. So the longer lasting insulin are basal insulins, and they were made to be available through this, the drug companies developing these different modifications to human insulin. In 2000, approximately 500 patients received transplantations of beta cells. These are the cells in the pancreas that make insulin. And they are still doing research on this, because the aim is to be able to transplant beta cells to such an extent that people with type 1 diabetes no longer need to supply insulin. But thus far, they haven't been truly successful with that. But just to let y'all know, that's in the works. And then in 2013, the University of Cambridge developed an artificial pancreas, which means it's not what you think. It's not like a robot pancreas or anything. Basically what it is you use a continuous glucose meter as part of an insulin pump, and they talk to each other. And basically the insulin pump automatically doses your insulin for you. So that's good news, because I haven't met an insulin pump that is accessible. Most of them now are touch screens, so you have to be able to have vision to use them. Some of the older ones had buttons on it. So the clients that I have that have insulin pumps that have no vision, they tend to have the older models with the buttons, and they have memorized what the buttons do. Or when they need to dose themselves insulin on their insulin pumps, they need to get visual assistance to help with that. So just because you don't have any vision and insulin pumps are not necessarily accessible, it doesn't mean that you can't get one if you need one. You have to really prove to the doctor and the diabetes educator that you can do it without vision, and come up with some adaptable ways of doing it. But the good thing about the artificial pancreas, some of the pumps now have sort of this capability where it will automatically deliver, all pumps automatically deliver a basal rate, which is like a little bit of insulin throughout the day, 24 hours a day. The times that you need to manipulate the insulin pump is when you eat or your blood sugar is high, and you have to tell the insulin pump to administer a bolus, which is a fast acting insulin, to get your blood sugar level back down. There are some pumps that will help calculate that dose for you, but it's not perfect yet. So hopefully that will come soon. All right, so there are different types and classifications of insulins. Right now, there are about 8. Like I said in part 1, all of this could be old news by tomorrow. They keep coming up with new technology and new medications, but as of 2021, the end of October, this is what's real. Okay, so 8 types of insulin: rapid acting, short acting, intermediate acting, long acting, intermediate plus short, intermediate plus rapid, concentrated, and inhaled. So basically, you've heard these terms: bolus versus basal insulin. So bolus insulin is like a one-time dose. You give yourself a dose of this, and it helps to lower your after meal blood glucose levels. So, when you eat carbohydrates, your blood sugar level is going to go up because your body metabolizes the carbohydrate into sugar. So you might need to take insulin with your meals so that your blood sugar does not raise too much and you get it back under control. So the way you know that a bolus dose is working is you check your blood sugar level up to 2 hours after you eat, and you want it to be below 180 or whatever your doctor says it should be. The other type of dose of insulin is basal dose, and this is the continuous dose. This is where your body gets a little bit of insulin constantly over a certain period of time, like 24 to 72 hours. With the new insulins being developed, there are basal insulins that last up to 3 days. So you do 1 shot every 3 days. So that's amazing to me. How you know a basal dose insulin is working and effectively lowering your blood sugar level is your fasting blood glucose level. So when you wake up in the morning, before you eat anything, you take your blood sugar. And if it's within your normal range, then you pretty much have a good idea that your basal insulin dose is the right amount of dose for you. Now, insulin, any medication has side effects. But I must say insulin is probably the medication that has the least amount of side effects because it is mimicking a natural hormone in your body. But there are a few. The main side effects are hypoglycemia, which is low blood sugar, and that happens when you give yourself either too much insulin or you don't eat right, or you give your insulin at the wrong time. Another side effect of insulin is weight gain. And the third one is lipodystrophy, which is a very fancy word for you developing skin lesions at your injection sites. This is why the doctors and nurses will tell you rotate your injection sites, meaning, inject yourself to the right side of your stomach one time, inject your in your thigh the next time in that area, because if you constantly inject yourself in the same spot, your skin tissue is going to get hard and you will not be able to inject in that site anymore. That's kind of what lipodystrophy is. So make sure you rotate your sites to decrease the risk of that. So the typical, when you first start out on insulin, typically your doctor determines your starting dose by your weight. Everything in medicine is done with the metric system, so we go by kilograms, but 2.1 pounds equals 1 kilogram if you want to do the conversion. Typically, you start out with 0.5 to 1 units of insulin for every kilogram of body weight you have. And then they figure it out from there. And then they titrate your dose up or down depending on how well that dose works. With insulin vials, once you open them, they're only good for about 28 days. And with the pens, it differs with each pen. So you need to find out what kind of pen you have to find out how long it's good for once you open it. All right, so now I'm going to start talking about the different types of insulins. So the first one I'm going to briefly talk about is rapid acting. So insulins are not only classified by whether they're a basal or a bolus dose insulin, they're also classified by their onset, peak, and duration. So onset means, you know, how quickly does that insulin begin to lower your blood sugar level? The peak is its utmost efficacy. You know, at what point, how much time does it take for it to reach its height of working? And then duration is how long does the insulin affect your blood sugar levels in your body? So rapid acting insulin mean just that. They act very rapidly. So these are insulins like Aspart, which is the generic for Fiasp. I don't really see that insulin very much. Lispro is another one. Novolog is one I see a lot. Humalog is another one I see a lot. And then Apidra is kind of popular as well. So these all have a little bit different onset, but basically Lispro is the fastest. It starts to work within 1 minute. So that means if you are taking insulin to cover the carbohydrates that you're eating with your meal, you need to remember. So Lispro starts to work within 1 minute. Its peak is an hour, and then it's in your body for about 4 to 5 hours. That's a kind of new insulin, so I haven't seen that one a whole lot with clients that I work with. The ones that I see the most are Novolog and Humalog, and they start to work within 5 to 15 minutes, and they peak at 30 to 90 minutes, and they're in your body less than 5 hours. And I think I stopped with TIE, the acronym TIE. So whenever you take rapid acting insulin, you are usually taking these insulins to lower your blood sugar with eating. So remember TIE. TIE stands for test, inject, and eat. So meaning, as soon as you test and you determine how much insulin you need to give yourself, you inject it and then you eat. Do not get sidetracked and do something else, because you see how quickly these insulins start to work. If you do not eat when you're supposed to, you're going to have hypoglycemia and you could pass out. So it's very important when you take rapid acting insulin to make sure you eat. So these insulins are dosed from your doctor as either a fixed dose. You know, the doctor might say, I want you to take 5 units of Humalog with every meal, or he'll say, I want you to do a sliding scale of rapid acting insulin, and they'll give you basically kind of directions, like if you take your blood sugar before eating and it's 150 to 199, I want you to take 2 units of Novolog. If it's 200 to 249, I want you to take 4 units. And if it's 251 to 299, take 6 units, and on and on. And usually they say if it's 400 and above, call me. But that's what a sliding scale is. So you really need to know what your blood sugar is so you don't give yourself the wrong dose. And another way they do it is carb counting ratio. So your doctor might say, I want you to dose yourself with rapid acting insulin with a ratio of how many carbs you eat that meal. So usually it's around like 15 grams of carbs is 1 to 2 units of insulin. It just depends on what your doctor wants you to do. But those are for people that, you know, are counting carbs. So they know how to count carbs. They know how to determine the amount of carbs they're going to eat in their meal. And then they have to do this equation to figure out how much insulin to give themselves to cover the carb metabolization that's going to happen with that meal. I hope that makes sense. So insulin pumps use rapid acting insulins. That's what they use. All right. Hold on, let me go to my next page here. So the next type I'm going to talk about is short acting. This is an easy one. There's only one kind, regular insulin. So this was the insulin that was developed back in 1921. So this insulin has been around for 100 years. Its onset, it starts working within 30 to 60 minutes. It peaks at 2 to 3 hours, and it lasts in your body for about 5 to 8 hours. Brand names for regular insulin are Humulin R, Novolin R, Relion R, and Aletin R. One good thing, regular insulin is going to have that big letter R with it. So if you have an R on your insulin, it means it's regular insulin. These are bolus insulins, which means, remember, it's used to lower your blood sugar levels after eating. It's dosed as a fixed dose, meaning you take a certain amount once a day, twice a day, 3 times a day, or sliding scale based on your blood sugar level or your carb counting ratio. This is an insulin that I like to tell people about, because in the past few years, insulin prices went through the roof. And, you know, people died because they couldn't get insulin because they couldn't afford it. Their insurance wouldn't cover it, or they were paying out of pocket and they couldn't afford it. So I tried to make as many people know about this as I could. Walmart has a brand of regular insulin called Relion R, and it's $25 a vial, and you don't even need a prescription. So if you know anyone, or you have diabetes and you have to take insulin and you cannot afford it, you can go to Walmart and you can get a vial for $25. Now, you know, depending on how much insulin you take, a vial might last you a week or it might last you a month. It just depends. But you still need to call your doctor to find out what your dose should be, because regular insulin has a different onset, peak, and duration than any other insulin. So don't just go get the regular insulin and take your usual dose, because that's going to cause a lot of problems. But, you know, let your doctor know that you can't afford your insulin. And if they don't have any resources to help you, you can say, well, hey, you know, Walmart has this insulin, and how can I take it so that I have something for my diabetes? All right, another type, intermediate acting, is NPH insulin. So this is also one that there's only one type of insulin in this class, NPH. This is also known as Humulin N, Novolin N, Relion N, and Aletin N. So this also, if you have NPH insulin, it's going to have the N in the name. The onset for NPH is 2 to 4 hours. It peaks in 4 to 10 hours, and it lasts 10 to 16 hours. This was the second insulin developed. It was developed in 1946. It is a basal insulin. So remember, I said basal insulin is the one that you get over a longer period of time, and it helps control your blood sugar levels between meals and at nighttime. Your fasting blood sugar level tells you how well NPH insulin is working. NPH, I've only ever seen it dosed as a fixed dose, but you might have a doctor that does something different. So usually they'll tell you, you know, take 10 units of NPH in the morning, and at night I want you to take 12 units, you know, just depending on what regimen your doctor puts you on.
I motion. Oh, well, Jill motions, I second.
And Relion N insulin, Walmart also has a brand, Relion N insulin of NPH, that also is $25 a vial without a prescription. So if y'all could mute, that'd be awesome. So this is another one. If you're having trouble affording your diabetes insulin, you can ask your doctor about NPH insulin through Walmart. All right, so long-acting insulins, there are basically 3. Detamir is the generic. The brand name is Levemir. Glargine is the generic for Lantus and Basal, and Degludec is the generic for Tresiba. So all of these are basal insulins, remember, so they last longer in your body. Your fasting blood glucose level tells you how effectively they're working. These are dosed as a 1 time a day insulin, the same time every day. So like Levemir starts to work in 3 to 8 hours. It does not have a peak and it lasts up to 24 hours. Lantus starts to work in 2 to 4 hours and it lasts for up to 24 hours. And Tresiba, which is a kind of newer insulin, starts to work within an hour and it lasts up to 42 hours. So you still might get Tresiba once a day. A few people can take it less often than once a day, but I still mostly see Tresiba once a day. So, these are ones, like I said, fixed dose, you take it once a day. Usually you take Lantus, start it at night, but any of these you can start any time of the day. Your doctor should let you know. All right, so there are some combination insulins. There is a combo of intermediate and short acting insulin, and this is NPH and regular put together. So remember, these are the two oldest insulins. So, back when I started teaching diabetes in the late 90s, all we really had was NPH and regular insulin. It's just been within the last 25 years that they've come out with all these different types of insulins. So a lot of times what would happen is you would get an order for NPH plus regular insulin, but they came in 2 different vials. So you would have to draw them up. You would draw them up in the same syringe. So you only have to do 1 injection, and you would always draw up clear before cloudy. So regular insulin is clear and NPH insulin is cloudy. So now they have them actually a combo together. Some people still have the separate vials, but it's just not as common. Now you can get them actually in the same vial, and they're known as 70-30 insulin or 50-50 insulin. So basically the 70-30 and 50-50 just stands for how much of each type of insulin they have. So 70-30 insulin would be 70% NPH and 30% regular insulin in the same vial. 50-50 is 50% of both. So this insulin is different because it's a bolus and a basal. So you're getting the dual peaks and the dual onset. So it starts to work within 30 to 60 minutes because it has that regular insulin in it, but then it lasts for 10 to 16 hours because it has the NPH insulin in it. But this would be a fixed dose from your doctor 1 or 2 times a day. All right, a combination intermediate and rapid insulin is known as Novolog mix 70-30. And Humalog mix 75-25 or 50-50, kind of the same concept. It's just the Novolog mix is 70% insulin aspart protamine and 30% insulin aspart. And Humalog mix is the percentage insulin lispro protamine with insulin lispro. So they both start to work within 5 to 15 minutes and they both last up to 24 hours. So once again, this one is a bolus and basal together. So it is dosed as a fixed dose 1 or 2 times a day. There is a concentrated insulin. So concentrated insulins, time kind of runs together for me, but I think I recall first hearing about concentrated insulins about 6 years ago. They're becoming more popular. They were developed so that someone who was taking a high dose of insulin could take less. So, maybe people that have had diabetes for a long time and they've had to slowly increase their insulin level, or they're overweight, and the more body fat you have on your body, usually the more insulin you need. So, you might be taking 50 units of regular insulin to cover your meals. Well, with concentrated insulin, you can take way less than 50 units. So rapid acting high dose U500 Insulin Lispro, also known as Humalog U500, is 2 times the concentration of U100 insulin. So meaning if you were taking regular Humalog and you needed 50 units, with Humalog U500, you would only need to take 25 units instead of 50 units. So this starts to work within 10 to 15 minutes and it lasts 3 to 5 hours. So this is also, because it's a higher concentration, it's also considered a bolus insulin, and it comes in a pen, and it is dosed as either a fixed dose, a sliding scale depending on your blood sugar level, or your carb counting ratio with each meal. Another concentrated insulin is ultra long lasting. So this will be a basal insulin, Insulin degludec, which is also known as Tresiba U200 or IDEG U200. This insulin lasts up to 48 hours. This one is also 2 times the concentration, thus it has 200 in its name. It also comes in a pen, and it is dosed as a fixed dose once a day. Ultra basal insulin is another concentrated insulin. This insulin is also known as Lantus or Toujeo, Toujeo U300. It starts to work in 6 hours, and this one lasts up to 36 hours. So it also comes in a pen, and it's dosed as a fixed dose once a day. So this one's also a basal insulin. Humulin regular U500 is a short-acting, high-dosed, concentrated insulin. So it starts to work within 15 to 30 minutes, and it lasts 13 to 24 hours. So this one is 5 times the concentration of U100 insulin. So this is indicated for patients that have to take 200 plus units insulin daily so that they don't have to take that much. It's really hard to fit that much into an insulin syringe. And most of the time people, you know, if you're taking that much insulin, you're doing 3 injections, 2 injections just to get the right amount that you need for one time. So you're giving yourself multiple shots. So this concentrated insulin gets it down to where you only need to take 1 shot instead of multiple ones. But U500 insulin uses a special pen, and you have to use it. You have to use it with the special pen or special syringe if you're drawing it up from a vial, because the dose is calculated differently. And the U500 insulin is both basal and bolus, and it works in a similar manner to the premix insulin that I talked about earlier, like the 70/30s and things like that. It is dosed as a fixed dose 2 to 3 times a day, 30 minutes before a meal. That's all of the insulin types. There is an inhaled insulin that's on the market. It's called a Freeza. It is regular insulin in an inhalation form. You inhale it like you would if you were an asthmatic and you used an inhaler. So a Freeza kind of works the same way. There's cartridge that you put into an inhalation unit, you put into your mouth, and then you breathe it in. It starts to work within 12 minutes, and it lasts 1.5 or 1.5 to 3 hours. Your doctor will tell you what unit cartridge to use. They come in either 4, 8, or 12. And because it's inhaled, the insulin passes quickly through your lungs and into your bloodstream, where it begins lowering your blood sugar level. There are some things to worry about. Your lung function should be assessed to make sure you don't have lung disease, because there is a risk of bronchospasm with inhaled insulin. And the side effects are not only the hypoglycemia, but also cough and throat irritation. All right, so that's it for insulin. I mean, as you can tell, a lot of them have like the same names. They just add 1 or 2 things to it. There's a lot of information about it, and it can be very, very confusing. I mean, I live and breathe diabetes, and I still have to have my cheat sheet with information so that I don't get something wrong when I tell someone. So, you know, I need to know about all of them, but what you need to know about really are the ones that you take. So learn as much as you can about them, you know, how quickly they start to work and how long they last in your body, and whether you should take it before you eat, after you eat, or at a certain time during the day. So I implore you all to advocate, you know, for your own health and ask your doctor or pharmacist those questions. The last kind of thing I'm going to talk about are some injectable medications that people think are insulin because it's a shot, but they are not. These medications are only for type 2 diabetes. Insulin is for type 1, type 2, and any kind of diabetes that you have, gestational, LADA, genetic types of diabetes. But these injectable medications are for type 2 diabetes. So they are a classification known as GLP-1 receptor agonist. They're also called GLP-1RA. These are incretin mimetics. They work to lower your blood glucose level in 3 different ways. They help increase the insulin release from your pancreas when you eat. It slows down your stomach from emptying so that you don't get a dump of carbs in your body at the same time, which raises your blood sugar level quickly. And it also promotes satiety, which means a feeling of fullness, so that you tend to eat less. And it suppresses the glucagon release from your liver, which is basically sugar. So that's how these work. They are injectable. They are known as exenatide, which is Byetta. You inject Byetta 2 times a day. Exenatide XR, also known as Bidurion, and you inject this one time a week. Liraglutide, which is also known as Victoza, that's a once a day injectable. Dulaglutide, which is also known as Trulicity, that's a once a week injectable. Lixisenatide, which is also known as Adlixin, is a once a day injectable. And then semaglutide, also known as Ozempic, is a once a week injectable. Bidurion and Victoza are the only 2 of these 6 medicines that are approved for children 10 years of age and older. All the rest are only used for adults. So side effects of these medications are nausea, vomiting, weight loss, and injection site reaction. You also could get pancreatitis. So if you develop severe abdominal pain or vomiting, you want to stop the medication and let your doctor know. There is a black box warning, which is a serious warning, that thyroid T-cell tumor warning for Bidurion, Victoza, Trulicity, and Ozempic. So if you have a family history of medullary thyroid tumor, you probably don't want to take this medication. The one good thing about these medicines is, especially the Victoza and the Ozempic, there's been a lot of studies done, and they significantly reduce the risk of cardiovascular death, heart attack, and stroke, which is the number 1 complication of diabetes. They also tend to lower your A1C level. Remember, I said you wanted it 7% or below. These tend to lower it by 0.5% up to 1.6%. And the other good, side effect of this medication, but I think it's a pro, is people tend to lose weight on these medications. From 3.5 to 13 pounds is what people tend to lose on these medications. So in the by mouth in part 1, Ozempic is semaglutide. They actually have a pill form of that one, and it's called Rybelsus, and that one is a pretty new. So you can either take the pill form of Ozempic or you can take the injectable form of it. All right, so there are some combination insulin and injectable medications, meaning those ones I just talked about, the GLP-1s. There are some combo medications that put insulin in those in the same vial. So this one is Ziltofi, also known as Ideglira. These names are crazy that they come up with. And this one combines ultra long insulin with Victoza. It comes in a pen. It's a once daily injection. You're going to titrate this one up. So usually the doctor will start you on a low dose, and then they'll increase it by 2 units every 3 to 4 days until you reach the dose that you need to be on. Another combo medication is Soliqua. Or Iglarlixy. These are so hard to say. This one is Lantus Insulin plus Adlixin, which is that GLP-1. This one also comes in a pen. It's a once daily injection, an hour prior to your first meal of the day. This one is also titrated until you reach your target. The last medicine I'm going to talk about is an amylin mimetic. This can be used for diabetes type 1 and type 2 if they're on insulin. So what this medicine does, it's called pramlintide. The brand name is Simlin. Honestly, I have never come across a patient that takes this medicine, but it's on the book, so somebody takes it somewhere. It slows gastric emptying and also suppresses glucagon release from the liver. It's usually a 15 to 16 microgram dose shot in the subcutaneous tissue, and you take it immediately before major meals. The side effects are severe hypoglycemia risk. So usually if you're taking this, your doctor will decrease your insulin dose when you first start it, and nausea and weight loss. It also tends to lower A1C levels 0.5 to 1%. So here's a review to wrap up: diabetes medications and low or no vision. You know, I implore you to empower yourself to be responsible for your medications. Do not let blindness be an excuse. You can do it. Insulin pens are accessible. You draw up a dose by turning a knob that makes a clicking sound. So each click of an insulin pen is 1 unit of insulin. So if you have an insulin pen and you're supposed to take 10 units, you just click it 10 times and you know that you drew up 10 units. So don't be scared of that. With insulin pen, you also just have a little needle that you screw onto the end, and it only goes on one end. It's only going to screw in on one side or the other. And then, you know, it's a little tiny needle now. They have little bitty needles now, so it really doesn't even hurt when you do it. So don't be scared of that. But, you know, research your medications. Like I said, ask your doctor about them, ask your nurse about them, your diabetes educator, your pharmacist. Pharmacists are the experts in medications. They know way more than I ever could proclaim to know about medications. Also, you know, you can research online. Just use, you know, reputable websites that I mentioned in part 1. Also, have a safe way to identify your medications. Down the line, I'm going to do a webinar on resources that help people with low and no vision identify and safely take their medication. So look for that, you know, things like script talk, braille labels, large print labels, etc. Also, you know, develop a medication management regimen that works for you. As long as it's safe and it allows you to take your medicine like you're supposed to, then, you know, use it. It doesn't have to be what your friend does or your mom does or whatever does. As long as it works for you, that's the main thing. And so I leave you with the 3 words: educate, advocate, and activate. Educate yourself, advocate for your health care, and activate your plan. I do want to mention, Chris mentioned in the beginning that I'm helping them update the Vision Aware website with the diabetes information. So there will be a diabetes medication webpage that has tons of information, even more than I mentioned on part 1 and part 2, that hopefully will be up soon if you want more information on everything that I talked about. So thank y'all. That does it for me today, and I look forward to the Q&A session in November.